start on time. So, good afternoon and evening, everyone. Again, I'm Professor Thelen Sakcha of the ISN OSEA, and it's truly a pleasure to welcome you all to today ISN OSEA CPC. Thank you for joining us from across our wonderful diverse regions. Now today case teaser is a pretty intriguing question. Could cannabis be the cupid here? We're going to follow the story of 43 years old with CKD, G3a, hypertension, and AKI who comes in with sudden edema and sky-high blood pressure. What triggered this sudden deterioration? Could cannabis be playing some hidden role? Let's find out together. The case will be presented by Dr. Thanawat, our second-year fellow, and Dr. Jilasit is our pathologist. We will review and comment. I trim in as the nephrologist as well, and we promise to keep you guessing till the end. As always, feel free to jump in, type your questions in the chat box, or unmute yourself to share your thoughts, and do let us know where we are joining from. You can interrupt us every time you want. Even if you're just listening in quietly, we're happy to have you. All right, let's get started. Over to you, Dr. Thanawat. Are you ready?
Yeah, ready.
Okay, go ahead.
Okay. Good afternoon, everyone. Welcome to CPC conference of ISN OSEA 2025. I'm Dr. Thanawat Sewafai, second year nephrology fellow from Chulalongkorn University. Let's start the case presentation of CPC conference. The patient is 43 years old, French male. He was restaurant marketing and born in France and currently live in Pattaya, Thailand. For admission in King Chulalongkorn Memorial Hospital. Chief complaint is progressive dyspnea for 7 days. Previous status is independent and can perform basic activity daily living and do anything else. 7th day prior to admission, he noticed that he reduced in urine output about half of other day. Subsequently, he developed dyspnea and orthopnea when he lying on the bed and requiring upright position to relieve the dyspnea. And he noticed that the leg have bilateral swelling. 4th day, for a later, he noticed that the urine output is reduced and worsening dyspnea and orthopnea and PND, and the leg was swelling, but it's marked swelling than 1 week prior. And he go to the clinic and taking some vitamin supplements and corazepate. 1 day prior to admission, he felt worsening of symptoms of edema, dyspnea, and orthopnea, PND. He still oliguria or decrease in urine output and leg swelling. He was no symptom of chest pain, palpitation, or syncope. There is no fever or weight loss or anorexia. No symptom of arthralgia, rash, or oral ulcer was observed. So he came to the Bang Lamung Hospital, that's a rural hospital in Pattaya for seeking the problem of the symptom. This is the physical examination and investigation of Bang Lamung Hospital. The vital sign, the blood pressure was 200 over 130 millimeters of mercury. The pulse rate is 86 per minute. Respiratory rate 20 per minute. And the respiratory system was 5 capitation in both lungs. The cardiovascular system is normal, S1, S2, and no murmur. And bilateral pitting edema for 2 us. Initial investigation, hemoglobin is 9 gram per deciliter. White blood cells and platelets was normal. About BUN is 124 milligram per deciliter or 44 millimole per liter, and creatinine is 16.6 milligram per deciliter. And electrolyte is shown in the slide. I create the graph about the creatinine and GFR for in the past of history of the patient. The baseline creatinine on October 2023 is 2.1 milligram per deciliter, and so he have CKD stage 3 for about 2 years, and creatinine on June 2024 is 1.8, and the creatinine is rising for about 8 months because they have no baseline investigation during the duration of 8 months. Okay, and the laboratory is hypoalbuminemia is 2.6 gram per deciliter, and urinalysis have proteinuria and hematuria. So about the azotemia and electrolyte abnormality, the doctor managed the patient at the Bang Lamung Hospital is stabilized about the hyperkalemia with calcium gluconate and glucose with insulin IV and calimate. And about acidosis of this patient, he give bicarbonate IV, and he said the physical exam of volume overload and hypertensive emergency, the doctor give nicardipine IV to relieve the blood pressure to normalize about 25% from the baseline. And then the patient denied treatment and transferred to continuous care at King Chulalongkorn Memorial Hospital. About underlying disease of this patient, the patient have deep vein thrombosis at left leg for about 6 months prior to admission. He present with left leg edema, and ultrasound Doppler confirmed that they have acute to subacute deep vein thrombosis in left common fibrillar vein and femoral vein and popliteal vein. No underlying of malignancy prior to the presentation. So the doctor work out for the thrombophilia like APS, yes, lupus anticoagulant or anti-beta 2 glycoprotein and anti-KRPin. So the lab showed that lupus anticoagulant positive by APTT and the RBBT test, but the lab was not repeat for next 3 months because he lost follow-up. About treatment of deep vein thrombosis, he was received apixaban 5 milligram per day, 8 months prior to admission. And the second underlying is chronic kidney disease stage 3B that for 1 year at private hospital in Pattaya. He present with brown urine for 1 week and history of NSAID used for pain at knee. The laboratory on 8 month PTA baseline creatinine is 1.8 milligram per deciliter or about 160 micromole per liter, and GFR about 45 ml per min per 1.73 meter square. And UA have proteinuria and hematuria for 8 month PT day. Ultrasound abdomen showed that the bilateral renal enlargement, right kidney and left kidney size about 14 centimeters is very large and increased parenchymal echogexity. They have cysts at the right kidney and multiple internal thickening of septum at lower pole of right kidney. So Bosniak 2F or 3. About personal and social history of unsafe sex for last 6 months ago with multiple sexual partner. He have no history of MFN because he have female sex partner and no condom use. He used cannabis daily for about 1 to 2 grams per day, and he have tattoo on the left arm and leg for 10 years. He denied history of blood transfusion or abdominal bleeding or over-the-counter medication. He consumed 2 drinks per day for about 3 years and discontinued for 3 months. He denied history of drug allergy. And family history, he have a thrombosis of his mother and his grandmother. About physical examination at King Chulalongkorn Memorial Hospital, the vital sign showed blood pressure high about 170 over 110 millimeter mercury, and pulse rate is normal. Respiration rate is 26 per minute. The oxygen saturation is 92% at room air desaturation, and BMI was about 26.8 kilogram per meter square. The physical exam showed mildly pale conjunctivitis and loss of temporal fat pad both sides. No oral ulcer, oral candidiasis, and oral hairy leukoplakia. The skin was normal, and respiratory system shown by capitation both lung. Cardiovascular system, the JVP is engorged to mandible, no LV or RV heaving, normal S1, S2, and no murmur. Abdominal exam show no distension and no sign of ascites. Extremity show pitting edema for 1 plus, both leg and arm. No lymphadenopathy, and neurological exam was appear normal except the eye ground, the fundoscope, seen heart exudate, cottonwood spot, and papilledema in retina. This is the initial investigation that show in the teaser that Dr. Selengsак sent you for before 2 days ago. The lab show anemia. Hemoglobin was 8.6 gram per deciliter. Baseline was 12 gram per deciliter, and white blood cell and platelets was normal. BUN is 122 milligram per deciliter, and creatinine is 18 milligram per deciliter. And show hyperkalemia, potassium was 6 millimole per liter, and acidosis, which bicarbonate is 12 millimole per liter. The UA show protein urea and hematuria like in the table, and hypoalbuminemia was persist about 2.5 gram per deciliter. And this is the laboratory show in the past and the day of admission, like in the table, and the graph of creatinine and eGFR shown in the graph. So the ask to someone about the problem list of the patient and approach.
Someone asking us in the chat box. So may I know what was the etiology of his previous CKD 3A? Hello, what do you hear me? You have to yeah, unmute yourself. You know what? Oh, okay. During his pausing.
The
Okay.
etiology of CKD is suspect NSAID use and no biopsy proven.
Okay. So the etiology that we suspected is NSAID usage. So till now, I really love to hear everyone's thought on this. So what are your opinions on how we should approach and give an initial treatment for uh, for patient situation? Anyone want to comment? Any thought from the Zoom? Any volunteer? Otherwise, I'm gonna start with Ruby. Ruby, do you want to try? Dr. Ruby? Anyone want to comment, give thought or anything?
Hello, hi.
Hello, hi.
I'm Durga from KL.
Oh, wonderful, wonderful.
Yeah.
Thank
Hi,
you so
I'm
much.
So
Oh, a
if
lot
I
of
could just
people there. A lot of people there. Oh, please.
yes,
Okay.
everybody's there. Dr. Sunita's there as well. Yeah, the whole team is here. So I would just like to say at this point of time, I think the patient is the most important thing right now is that he's actually presenting with an acute on chronic kidney disease with hyperkalemia and metabolic acidosis. And he seems to have features of suggestive of a nephritic syndrome because he's got volume overload, he's got edema, he's got the hypertensive emergency together with target organ damage in the form of retinopathy and possibly even the kidney involvement. And he's got the urine sediments with the blood and the acute kidney injury. So I think that's the main problem list at this point of time. So probably the most important management at this juncture is to investigate further by quantifying protein and to get an ultrasound urgent, given that the patients have some cysts and lesions in the past. So that would be good to look at the progression of cyst and also to look at if there's any obstruction going on that's doing this. And also other investigations probably do a full blood picture because it does have anemia, and then to send other viral screenings like hepatitis B, C, HIV, and syphilis because it has high risk behavior in the past. Sorry, high risk behavior even currently. And also to look for other causes that might be pushing him towards this accelerated impairment of the.
So wonderful, but while waiting for the answer of the give you information of the labs. So the patient have high BUN, creatinine, potassium is 6, and severe acidosis, phosphate 14 or 15. You start something first, or you just waiting for the other additional labs?
So I would want to dialysis. I got disconnected, if I could say it. And of course, initiate emergency dialysis at this point of time because he's got hyperkalemia and metabolic
So which
acidosis
modality that
volume
you're going to
overload.
choose for the patient? Which
Hemodialysis.
modality?
I'm going to do acute hemodialysis. Acute hemodialysis.
Why not PD? Why not PD? I thought you were a PD lover. Why don't you start PD? Acute PD.
Not in this situation. In an acute situation, I
Okay.
probably want hemodialysis. More control.
Okay. That's
yeah.
good. Usually people have a HD as a default mode. Okay. Thanawat, please give information, additional information, and also labs as well that our friend are asking. Probably the microphone in the my conference hall is not good. Thanawat, do you hear me?
Yes.
Okay.
About the workup
So you
for
start in
anemia.
initial HD character insertion and start dialysis, or you start PD, or you do nothing.
Okay. When the patient came to the hospital, the laboratory showed azotemia and refractory hyperkalemia and metabolic acidosis, and the physical examination showed signs of volume overload, that is fragmentation and pitting edema. So the emergency management was given calcium gluconate and glucose insulin for IV, and then discussed with patient for about the renal replacement therapy. So we choose hemodialysis mode to remove for remove fluid, uremia and hyper-K. So the first session of hemodialysis, we are like internal jugular catheter, and set first session for about 2 hours and isolate UF for 3 liters for 2 hours. And then the further investigation that the floor asks about the ultrasound and viral serology. The ultrasound of KUB show right kidney and left kidney size about 9 and 11 centimeter and increased parenchymal echogenicity, no hydronephrosis or hydroureter, and found the right renal cyst about 7 centimeter with internal septation and echogenic content on the right kidney. So we use the Doppler ultrasound to focus about renal vein and renal artery. So both renal vein and artery was patent and no evidence of thrombosis. About anemia workup, we hemoglobin is 8.6 gram per deciliter and MCV was 87 is normal and RDW is 13% is normal. White blood cell and platelets was normal. So we sense the reticulocyte count was 0.9%, absolute is 24,000. And we look for the peripheral blood smear, show no hemorrhagic blood picture and no MAHA blood picture. Platelets was normal. And we sense about the CUM test is weakly positive, but the blood smear no show no hemorrhagic blood picture. And viral serology that you asked, the anti-HIV was positive. Other serology like hepatitis B or
You should
hepatitis
not
C and
too
tripolymer antibody was
early
non-reactive.
to review that. Okay. It's happened to accidental is fine. Okay, go ahead. So go ahead and continue. So because people already see that, okay, let's go back to a hospital of KL. So would you like to list the problem for this case before we start approach the case? Hello, or anyone else want to list the problem before we start approach the case?
Hello, good afternoon. I'm Jim. I'm from HKL.
So we cannot
Hello.
see your beautiful group's photo. But okay, so back good. So
Yeah, hi. I think that from this case, what we can summarize that this is actually a middle-aged gentleman who presented with acute kidney injury with hyperkalemia, metabolic acidosis, and also newly diagnosed retroviral disease. And upon, I would think that we should, how do we approach this patient in a manner whereby we should divide into acute management and also the chronic management. So in terms of the acute management, we would like to insert a femoral catheter and also to dialyze the patient first to stabilize the patient. And slowly we should work out on the causes of the rapid declining of the EGFR, whereby in this case,
so the signal is not good. We're waiting for the signal from the hospital of KL. Anyone want to express any idea? Dr. Jing or Dr. Luby or Dr. Min? Anyone want to,
Yeah.
do you want to raise any comment or raise the process finding of the case?
I think the list of the problem will be, number one will be the acute injury, hyperkalemia, metabolic acidosis, newly diagnosed retroviral disease in a middle-aged gentleman here with a rapid declining EGFR.
Good. But probably your signal is not stable. Your internet signal is not stable. Okay. Now I can see probably you can you can closing your camera, so maybe the signal maybe a lot better. Okay,
All right.
go ahead, please. Go ahead.
Yeah, I would like to recap. I think this is a middle-aged gentleman with acute kidney injury, with hyperkalemia and metabolic acidosis, with also newly diagnosed retroviral disease, with also concurrently having a fast, rapid declining EGFR, whereby I think we should actually opt for acute hemodialysis in view of the blood parameters which is shown in the list here, whereby the urea is 43, while the creatinine is 1006 with potassium of 6.0 and a bicarbonate of 12 millimole per liter.
Good. And so what is the etiology of AKI on top CKD?
Now that we know that it is a newly diagnosed retroviral disease, probably we would think along the line of HIVIC, or maybe hepatic kidney disease.
And how about the urine that the patient complained that he got a dark urine? Do you still think of HIVIC or HIVAN thing?
post-GN, or it's a maybe it's a post-strap GN or some form of like acute kidney acute tubular necrosis, AIN, sorry, acute interstitial nephritis. I would like to actually order for creatinine, creatinine kinase level.
What do you have CPK level or the other muscle marker?
The CPK was about 120. Is normal.
Okay, and when he arrived to our hospital, his urine turned brown, not dark, and then followed by dark yellow. So the blood test in the urine is positive 3+, and we see a lot of red blood cell. And I'm not quite sure that you already reviewed the urine sediment, right? I'm not quite sure that you already display.
Yes, it's
The morphologic finding of urine sediment.
from the first smear of urinalysis at the admission. We found dysmorphic red blood cell, but not seen red blood cell cast or any cast or crystal.
Okay, so we found dysmorphic red blood cell for how many %? Do you have you see the characteristic cell like a acanthocyte?
Okay. I found the acanthocytes for about 10% and dysmorphic red blood cell about 40 to 50%.
Okay, dysmorphic red blood cell 40 to 50%, and acanthocyte 10%, no red cell cast.
Yes.
Okay, so we rule out the rhabdomyolysis, even the patient complained of dark urine, but because probably it's not too dark, it's because we don't see the dark urine, it's like a muddy brown, or Coca-Cola, probably maybe hemolysis from clot hematuria. So what is your final diagnosis? Or any labs that you ask for more? Or maybe someone else, Lubas, want to have any opinions on that?
Hello everyone. Yeah, like looking at this picture, I would definitely like to rule out some other causes of nephrotic syndrome too, because yeah, we can definitely say it could be a HIV-related HIV in the picture, but since the presentation was very rapidly declining to look for any crescentic glomerulonephritis. That's what I think, and maybe the brown color was due to not like the rhabdomyolysis or myoglobin. Could it be due to the acute tubular necrosis? Like the patient had decreased urine output, decreased dark urine with. That's what I feel. I don't know, like how much if that is.
Okay, good. So probably you Thanavat, you go to the viral profile of the case. So we actually work up on the patient serology as shown here, and because seropositive, so we assess the absolute CD4 count. So his CD4 count is 4%. And do you have a HIV viral load, Thanavat?
HIV viral load is about 2 million.
2 million. Okay.
Yes.
Before we go to walk to the biopsy, anyone want to guess the pathology finding? Because the patient is complicated. He has a CKD stage 3, present with a severe hypertension, AKI, high K, metabolic acidosis. He used cannabis NSAID, and also he have HIV positive. Anyone want to guess before we go to and we walk to the pathology? Maybe I gonna ask our Thai volunteer. Surasak, do you know the case? Surasak, do you hear me? Unmute yourself and respond. Or anyone else?
Good afternoon. They're from HKL again.
Okay, good.
I will try.
Back to KL.
Can it be collapsing FSGS?
Sorry, I cannot hear you well. What is it?
Can it be collapsing FSGS?
Okay, first, the first provisional diagnosis is collapsing FSGS, and you have a differential diagnosis for the case.
Crescentic glomerulonephritis.
CG crescentic from immune complex or ANCA associated or something.
Yeah.
ANCA. Okay. ANCA associated crescentic GN. You have any other or just 2 is enough?
Membranoproliferative MPGN.
MPGN. Okay. Do you differential TMA or antiphospholipid syndrome because the patient have and lupus anticoagulant positive and also have a history of deep vein thrombosis? Okay, because the time is quite limited, so we're gonna go through the pathology. So would anyone like to volunteer to help with the slide? We have LM, IF, and EM as well. And help describe what you are seeing. Thanawat, go ahead to the pathology. Start with LM, okay. Hospital, okay, how do you want to read it? While waiting, Dr. Jing, do you want to try? Or Ruby, or Surasak, or anyone from Singapore or Philippines?
Sorry, doctor, but I don't have any experiment in the pathology because in my country, when the sample,
okay. Understand. It's okay. Thank you, Dr. Jing. Ruby, do you want to try some?
Hello.
Oh, probably we have to go back to Hospital of KL.
Hello, hi. Durga from HKL.
Okay, thank you. Okay.
So this is a low power field view. There are 2 cores seen. And there are about 10 gloms. I think this is a past stain because you can actually see the basement membranes. And the tubules are not back to back. I think there are some interstitial, the interstitium looks like it has a bit of infiltrates there.
Oh, that's good.
The glom looks very, very crowded. It looks like it has a lot of cells and cellular component there, maybe proliferation. Yeah, or hypercellularity. Probably.
Oh, you have an eagle eyes. You can see during the low power.
Yeah, no, I think because
I actually agree. I completely agree. She has a very good eye.
Busy.
She can make out many things on this low magnification.
Okay, go ahead and second slide, please. Next slide. Next slide.
So I counted the number of glomeruli for you and tried to mark out the areas where the tubules are preserved.
All right. So this is again a low power field, and again 2 cores. This is a silver stain. The tubules in those areas are preserved, but they look. Wait, look at this.
You can just tell us like the overall
There are
impression. You don't have to go to
there.
the specific details.
Yeah,
We'll have the higher power
there.
fields of the pathology for you to look at.
All right. So yeah. Okay.
So there's a lot of scarring, right? From low power. The tubular interstitial scarring is like 70%, and there are around 15 glomeruli, and almost half of them are globally sclerosed, right?
I have to introduce a little bit. Dr. Gilasis, he is our pathologist. So please go ahead and read it, and he will interrupt you for a while because we have a limited of time. So he probably will teach you during your read the slide.
I'll be helping.
Okay. Okay.
That's great. Thank you. Okay, so this is H&E stain. Okay, so this is a single glom. It's a high power field. It's I think it's a H&E stain because I don't really see the basement membrane.
That's right.
Is there that looks like a crescent because there are more than 2 layers of cells. There is the capillary loops are not open, and there is some mesangial hypercellularity and also endocapillary proliferation. There's a lot of infiltrates as well in the interstitium.
Everything you said is accurate and correct. And there is also like a lobular accentuation of the glomeruli, right? Yes. There's lobular accentuation. And it looks kind of lobulated, right? So it's called lobular accentuation. And if you look at around 1 to 2 o'clock, you can probably see that the capillary loops are a little bit thickened. So what do you call the constellation of these findings?
Membranous proliferative.
That's right. This is a membranous proliferative pattern of injury with a cellular crescent. This is just a picture of the same glomerulus on a different stain. This is a trichrome stain. So if you look at around like 2 o'clock, you can see that the capillary wall stains a little bit differently. Those are the immune complex deposits that you can actually see on trichrome stain.
Yeah, it's just repeating the same thing over and over again. It's the same glomerulus. You can see the membranal proliferative pattern of injury is circumferential cellular crescents. And you might be able to see double contour a little bit more clearly on this stain, particularly at like 9 o'clock. 9 o'clock. Could you point to 9 o'clock? Yeah, like right about there. You can see like GBM duplication, right? Just to show you, there are just so many crescents, so many cellular crescents, right? Next would be. And this is just tangentially sectioning glomerulus. It cuts through the crescent without any glomerular tufts. This is a cellular crescent. Okay, and this is a glomerulus without crescents. So it's just endocapillary hypercellularity. And these are some chronic lesions, and this is a globally sclerosed glomerulus associated with a fibrous crescent. So this process has been going on for a while now. It's chronic. Next would be this is a segmentally sclerosed glomerulus. You can see that on the lower side that the capillary loops are kind of open, but on the upper half it's obliterated with PS positive material. These are called segmental sclerosis, and it's also associated with the fibrous crescent as well. You can see the disruption of the Bowman capsule. And the same glomerulus with crescents with lobular accentuation and PGN pattern. And you can see the GBM duplication.
Dr. Jesse, can I interrupt you a while? Can you point the lesion that you described? Because some of fellow cannot follow you. Is possible that you have put a pointer on?
Yeah, we have a pointer. Okay,
Does it not show up in, yeah.
There's a kind of a lag. Okay. Like it's lagging a little bit.
Okay, that's fine.
I'm trying to move the pointer, but it's lagging.
Okay.
Yeah.
Oh, go ahead.
Oh, here, I it's working now. So why are there two pointers? Okay, never mind. Right here is where I was telling you there is GBM duplication. The capillary loops are all filled up with cells, that that's endocapillary hypercellularity. You can see like lobules of glomerular tuft, that's lobular accentuation. And these cells are essentially cellular crescents. Right? Am I pointing correctly? I think it's showing next. So this is a low power field of the biopsy. If you zoom in, it's very blue. So there are lots of interstitial inflammation, right? It's just to show you that it's diffusely inflamed, both the cortex and the medulla. And now we're moving on to the tubular interstitial compartment. So there's tubular injury. These tubules are flattened and the lumina clear dilated, and they have lost their rush borders. Yeah. And there are like necrotic cells in the tubules, so there is acute tubular necrosis as well. And look at this arterioles. It's occluded by an eosinophilic material, which is most likely fibrin. So this is an acute TMA. Next, this is an artery. It's probably an interlobular artery, which is pretty much essentially normal. And you can see a little bit of tubulitis here, that these lymphocytes are invading into the tubules, or they're attacking the tubules. So it's not just non-specific inflammation, it's active tubular interstitial inflammation. And interstitial inflammation is so severe that you can see that on silver stain, the tubular basement membranes are disrupted. So this is tubulorexis from severe tubular interstitial inflammation. And the inflammatory cells are mostly mononuclear cells, but if you look carefully, there are like a little bit of eosinophils and some neutrophils as well. And this is another picture of tubular rexus. And last but not least, you can see that these tubules are, these clusters of tubules are dilated. And this would be consistent with the tubulars, with a microcystic dilatation that you typically see in hyphen. But in this case, we didn't see any collapsing glomerulopathy, but we did see some segmental sclerosis, which could have been a collapsing lesion. And then as the lesion progressed, it turns into an NOS pattern of FSGS. I think that's it for should I just carry on? We have like 5 minutes left. So we did immunofluorescence staining. IgG was positive in the mesangium and capillary loops. It was a granular pattern. So I gave this a 2+. IgA is also positive. That's a 2+. IgM was positive. That's a 1+. C3 was positive. I gave this a 2+. And C1q was also positive. That's a 1+ with all pretty similar patterns. So that's a full house staining. But the light chains are a little bit unusual because kappa was trace and lambda was 2+. So there was an impression that there was a light chain restriction in this case. And EM just confirmed the presence of immune complexes in the mesangium. And there's a little bit of deposits under the endothelium. So this is subendothelial deposits. And we also have tubular reticular inclusion, which is a sign of high interferon state. And in this setting, it's probably related to HIV infection. Right. So that's it for pathology.
So for the final pathology diagnosis and pattern, what maybe you conclude a little bit for our fellow, or maybe can
all right. So this was my diagnosis. It was lupus like glomerulonephritis in the setting of HIV infection, and I gave the pattern. It was proliferative membranous proliferative patterns in like 20%, and most of the glomeruli are sclerosed. So diffuse sclerosing glomerulonephritis with like about half, 50% crescents. And I noted that lambda was much stronger than kappa, so paraprotein should be excluded, and possible etiologies could be infection, could be autoimmune diseases, could be, I put mixed cryoglobulin in there because there was lambda restriction, and there was a component of chronic active tubular inducial nephritis, and we did some immunostain, which we didn't show, but it was CD4 predominant, so it's probably consistent with a diffuse infiltrative lymphocytosis syndrome. And we did some stains to exclude infection that includes the CMV, SV40, HSV8, and EB. We did EBER, so that excludes any EBV associated processes. And there was no immune complexes in the tubular interstitium. We also did acid fast stain, which was negative, and we did silver stain, which is also negative for fungal infections. There it is. And there was acute, TMA. Yeah, and there was probably a moderate to severe chronic changes. Yep, that's it.
Okay, thank you so much, Dr. Chilesis. So, given all this last or the patient diagnosis as a lupus like GN in the seropositive and TMA likely from severe hypertension, and after excluding so many possible infections, so AIN possibly linked to the drug or even HIV itself. So, Thanamat, because the time is limited, you progress the case a little bit and maybe give us the information about this kind of disease.
We talked about HIV-related kidney disease. There are approach from the patient with HIV infection and AKI or kidney disease, like other case.
We have 3 minutes for you.
Yes, glomerular, tubular interstitial, and vascular cause. But the most common cause of HIV associated kidney disease is high wick and high van. The differentiate of the two condition as high-1 is associated with ApoL1, especially in African race, and associated with high viral load of HIV. The pathophysiology is from direct HIV infection to podocyte and epithelial cells of tubular epithelium. The
Leukocyte high-1 present with the pure nephrotic syndrome without active sediment. For high-weak or low SLE associated HIV associated SLE or lupus nephritis, they present with regular SLE like active sediment, AKI, or AGN, RPGN, something like that.
Okay. And we will.
And what you treat the patient and give
Okay.
us the prognosis or natural cause of the disease, and also the progress of the patients.
After kidney biopsy results, HIV associated immune complex kidney disease, we perform hemodialysis for 2 times per week, and residual urine was about 500 to 800 milliliter per day, but the BUN is rising for 20 to 30 milligram per deciliter per day. So this dialysis dependent, and after the kidney biopsy results, we discussed with the patient about the management of this case, because high-risk have no standard guideline for treatment. So about the pathology of RPGN, like crescentic GN and TMA. So we offer the choice of plasma exchange for remove immune complex that's circulating in the blood system and immunosuppressive. And I discussed about the risk of infection, like opportunistic infection that may persist if we give the immunosuppressive drug. So the patient agree to go on the treatment. So we plasma exchange about 6 sessions and give the immunosuppressive about prednisolone to 0.5 milligram per kilo per day and oral cyclophosphamide 100 milligram per day. But the results of the case, BUN and creatinine not recoveries. So we discussed about the patient what to discontinue the plasma exchange, but continue immunosuppressive, and he want to go back to France for further treatment and continuing care. So I suggest that if the HIV was controlled by ARV, this patient, the infectious specialist gave him about the antiretroviral regimen, abacavir.
So the case been prescribed by antiretrovirus, and also we're gonna give the immunosuppressive. We try to avoid aggressive immunosuppressive. We actually want to prescribe like rituximab, but the patient have to pay by their pocket, and because he is French, it's not Thai, so it not fall into the universal coverage in Thailand. So he decided to go back to his country. So that's why we just have a preliminary result from the case. So hopefully, if he come back or if we got the follow up of the case, I will follow. I will later follow up to you guys. So thank you everyone for spending your time with us today and for all your living participation, and big thanks to Dr. Thanawat and Dr. Jirasit for presenting such a fascinating case, and to all of you for the great discussion and insight share from across our region. So the recording of today's session will be up on YouTube soon, and we will share it in the chat box. So feel free to forward it to your colleagues or trainee who cannot join live. So and tonight and in the evening time, we also have ISN, OSEA, CKDU. We is got the very renowned professor and legend professor, Professor Richard Johnson and Vivek Jha will give the talk. So please register to the ISN Academy. Before we wrap up, may I invite you everyone to turn on your camera for a quick group photo. And while waiting, so Dr. Lily, our deputy chair, she's driving, so she cannot close the session. So please open your camera for a while, and I'm gonna speak during take a group photo. So hope to see you again in our next webinars on November 25th, 2025, with the PD case from Singapore General Hospital. Anyone?
Could I interrupt you for there was one question about non-lupus full house nephropathy. I think the question was, could you share some insights about non-lupus full house nephropathy? In my opinion, it's not a specific entity. It's just a pattern of immunofluorescence staining. It's not specific for anything. It could be like infection. It could be lupus. It could be autoimmune disease, other autoimmune diseases. I think it's just important to correlate that with the clinical findings and identify the etiology. What do you think?
Yeah, that's good because we have if we have a coincidental diseases, so it's difficult to say what is the real etiology. The good way for us as a clinician, so we treat it all and see what happened, and then we withdraw one by one and see what happened. So because we have a short time to follow up the case, so we give the whole package. So we prescribe the antiretrovirus and also immunosuppressive as well, because the pathology is quite severe, and hopefully that we can update later on if the patients come back or respond to us with email. Okay. So hopefully we'll meet each other this evening for ISN or OSEA CKDU, and also the next webinars on PD case discussion on November 25th. And until then, good luck and have a great day. Thank you so much for everyone, and see you soon. Bye bye.